будь ласка, Girish Datar, Access and Approach of Extraforaminal Herniation.
Good morning, everyone. It's a pleasure to be here on this dais again to speak on not a very uncommon topic, endoscopic approaches to extraforaminal herniations. Extraforaminal herniations are not very common, but are responsible for a lot of pain because of the tight area in the foramen and in the extraforaminal region. Till now, the only approach, the open surgery, was the Wilsey's approach, and the second kind of an approach was a transforaminal approach. But extraforaminal pathologies coexist with other pathologies in the lateral recess and the foramen, so we need to devise different accesses and techniques to access these kind of herniations. So extraforaminal herniations are known to cause severe pain due to compression of the exiting root in the area, and if you have a foraminal component of the herniation, then you have a lot of pain related to the dorsal root ganglia. In some cases, technically, access to the pathology would be very difficult, especially at L5S1s due to high iliac crest, the large transverse process of L5, ala of the sacrum, and large superior articular process with a narrow foramen at L5S1. The various accesses that are possible for extraforaminal herniation is classical posterior lateral approach, that is the transforaminal surgery. Second is a paraspinal approach, which can be performed directly landing in the area in the paraspinal region. And third would be over the top contralateral axis. So I'll show you a brief example of the technique of how these three things are done. The over-the-top contralateral technique is one of the procedure that is performed for multifocal pathologies, as I showed you yesterday. When you have a component of lateral recess, you have a component of disc herniations within the spinal canal and an extraforaminal pathology, which are responsible for symptomatology in the patient. So the transiliac approach sometimes may be difficult, and maybe some people may not be very comfortable with the transiliac approach. So other approaches may be necessary. So first we'll see the posterior lateral axis, which is a classical transforaminal surgery that you dock completely extraforaminal. You don't have to get into the spinal canal. You dock extraforaminally and you start with the surgery. Here is a representative case. You can see an extraforaminal herniation. Completely I have depicted it. Marked it in red color. The classical transforaminal approach we perform by using it. Now the needle is able to go inside because it can go through the herniation, but most of the times your dilator and sleeve may not be, because most of the transforaminal surgeries that we perform are under local anesthesia, and putting in a dilator, which is about 7 millimeter dilator, may be extremely painful for the patient. So the needle is possible. So if you are able to access the needle through the herniation into the disc, it is good to stain the nucleus, because this staining will make the anatomy very clear in the extraforaminal region, because it will stain the degenerated nucleus material, which is acidic. So the first thing that you see when you get inside, when you are in the extraforaminal region, is you are always little caudal, near to the caudal pedicle, because that is the safe zone. The anatomy in extraforaminal herniations may have altered, so it is better to go caudal and then gradually make your way up cranial. So you just start removing the part of the fat in the lower part of the foramen, and then you can start doing your discectomy. As you start doing your discectomy, the exiting root will come into your picture. So you have to be careful from all the sides that when you're picking up the herniation to make an effort to see. Once you remove the herniation, you can see the annular rent, you can see the exiting root, and you can follow the exiting root all through till the axilla and going down in the extraforaminal region, that is dipping down. Some amount of tissue or everted margins of the annulus may be present, which can be taken out in chronic cases of herniation. The second axis, which is done very easily, is a paraspinal approach. The paraspinal approach, the original technique is you dock at the pars intraarticularis, you drill a part of the pars intraarticularis, then drill a part of the tip of the superior articular process, and then go inside. Now this technique we have modified a little bit. I'll show you why we have modified this technique. The important thing is we need to understand that the tip of the superior articular process is an important structure. In fact, in the natural history of degeneration, the disc height collapses. So when does the disc height stop? Only when the tip of the superior articular process abuts against the cranial pedicle, the collapse in the segment stops. If you take off the tip of the superior articular process, then you have an accelerated degeneration, that the degeneration will continue and the foramen will collapse so much that it will become a pinpoint foramen. So in cases where tip of the superior articular process is not part of the pathology, I would like to retain it and not touch it, or especially the dorsal aspect of the tip of the SAP, which should be retained so that the natural history of the progression of the degeneration can be halted. So you can see here now, this is the extraforaminal herniation, foraminal extraforaminal herniation. Quite a tight, not a very big herniation, but yeah, quite a tight herniation. So there's no instability in this case. So the classical approach, the stenosis is up, down, or front, back. So the tip of SAP is important, as I discussed with you. So we have to retain the tip of SAP. So we have changed the entry point from the pars to the transverse process. So we no more land on the pars interarticularis, but we land at the level of the transverse process. You can do a foraminotomy and directly get into the axilla, because the intention is not to de-roof the exiting root, but to remove the herniation and decompress it. So this is our access route. The first thing that you do is go inside is clear the soft tissues to see the transverse process very well and the superior articular process. So you can see here the superior articular process, the pedicle, and the transverse process. Now it is important to define the SAP. So you just have to follow the dome of the foramen. So you just clear it off with all soft tissues so that you can differentiate it completely in case you have to go inside the foramen completely. So this is the tip of the SAP, this is the base of the SAP, and follows with the transverse process. Now, important thing is the ligamentum flavum, when it comes extraforaminally, attaches to the transverse process and continues as intertransverse ligament. Now this intertransverse ligament needs to be removed for you to gain access into the intertransverse plane. So you can see here, I'm removing the part of the attachment of the ligamentum flavum, or you may call it as intertransverse ligament, to gain access, and immediately underneath is going to be the fat. The moment you remove the fat, this is going to be the beginning of the vision of the exiting root, extraforaminally. Here you can see the exiting root, very, very clear. So once you've done, you can anticipate how much of space is there caudally, and then you can drill the base of the pedicle, the part of the SAP, and a little bit of the transverse process to have more room, because in older patients, you may have a lot of osteophytic growth here, growth of the bone. So then it may be difficult for you to get the herniation off completely. So a little bit of drilling is going to be useful. So you drill caudally, you are not going cranially at any point of time. All the osteophytes which are placed at the base of the pedicle can also be removed so that you have a clean-cut access to the area. Now, if you want, you can go above the roof of the axilla to also have a look into the lateral recess. So you can see the traversing root already. This is part of the ligamentum flavum which is underneath. So you see roof of the axilla, the traversing root, and the exiting root. Once you have cleared the whole area, anatomy is pretty clear, and now you can proceed ahead with discectomy. Usually the upper layers are, if it is a chronic herniation, you would find it to be tough. Now this procedure is done under general anesthesia. So you have an opportunity to mobilize the root. So you find all the hidden herniations which are gone cranially underneath, and you can remove the entire part. If you think there is also a coexisting foraminal stenosis, you can take off the ventral part of the superior articular process with the Kerrison ronger, which is easily possible here. Modulate the annulus, and here you find the completely decompressed exiting root. Confirm the decompression completely, that there is nothing underneath. You may find some everted margins of the annulus, which is collagenized, which can be taken off in bits and pieces. A final annuloplasty and shrinking of the nearby tissue till you see the entire root coming from the canal to the extraforaminal region can be seen here, and that marks the end of the surgery. The third is over-the-top contralateral, as we discussed yesterday, when we have coexisting pathologies like pathology in the lateral recess, in the foramen, and in the extraforaminal region. So you can deal with all these three pathologies in one single go if you come from the opposite side. So here is a representative case. You can see a large herniation on the left side, extraforaminal herniation, lateral recess stenosis, and foraminal stenosis. So you come from the opposite side. So you come from the right side, do a little bit of drilling of the cranial lamina, which I'm doing here. You can see the spinolaminar junction and drilling of the cranial lamina. You get an access on the contralateral side. The moment you get an access, you start decompressing, remove the ligamentum flavum there, and you start seeing the exiting root. Your area is going to be between the traversing and the exiting root. You can start decompressing it by removing the disc herniations, piecemeal. Sometimes you have calcified herniations here. You have to use an osteotome to get it off. So this is the confirmation that I'm in the area, the extraforaminal region. This is the post-operative MRI of this patient. So full endoscopic foraminal decompressions, advantages of multiple access routes depending upon anatomy and coexisting pathology. It's a very targeted surgery that you don't have to really take off the facet joint. It is completely facet sparing. There's no need of fusion just for the sake of taking off a herniation, and when there is no existing instability in this case. Patient's recovery is very fast, usually the same day or maybe 24 hours later the patient can be discharged home. Thanks a lot for your patient listening and the opportunity.
Thank you very much, Girish.